Good morning, everyone. Thank you for joining us today. We are in person at the Mill Mountain Conference Room, and we thank you for joining us online. Today our presentation is by our very own Dr. Nima Jahromi, one of our current third-year chief residents. He earned his undergraduate degree in biology at the Virginia Commonwealth University in Richmond, completed his osteopathic doctorate in Las Vegas, Nevada at Toro University. He plans on starting a GI fellowship in North Carolina at Wake Forest in the upcoming months. During his time here, he has served as a PEC rep. His QI project has included type 1 diabetes mellitus screening in newly diagnosed patients with celiac disease. Please join me in welcoming Dr. Nima Jahromi.
Thank you for that introduction. Before I get started, I want to give a special thanks to Dr. Drake, Dr. Tillotson, and Dr. Lockney for helping me prepare this presentation and help me with these slide sets. We're going to just jump right in because we got a lot of slides to get through. I'm trying to do my best to kind of do more graphics and pictures, but I'll be talking a lot throughout it. If I talk too fast, let me know. We can slow it down. No financial disclosures, but I'd like to disclose I am going to fellowship, so I am a little biased presenting this. With some objectives, I do want to mention, when I refer to a pediatric subspecialist, I'm referring typically and generally to pathways through general peds, so not like including like peds surgery or peds anesthesia or something like that. Just jump right in. I think it's no secret that there's a growing demand for pediatric subspecialists. Part of that reason is because of advancements in medical technology and treatment modalities. We're having chronic disease survival rates, increasing. Kiddos who formerly would not survive past young childhood or birth are now surviving into their teens or even to adulthood. This is requiring more and more subspecialists to care for these chronic kiddos or for these more complex kiddos. And the bottom line is the supply is not keeping up with demand. We'll go through the numbers pretty in depth, but I'm sure we're all pretty aware of that, both on the subspecialist side and also on the gen ped side. This was a really good survey that they did by the AAP. They surveyed members on their periodic survey, and basically they asked a bunch of primary care pediatricians what they thought was their experience with the supply of the subspecialists in their specific area. And so this is them reporting what fields they felt were either too long of a wait or that had shortages in their area. So if you notice some of these general pediatricians, 97%, some of these, and even the lowest ones are still 15, 20%. So still a fifth of pediatricians, even at the lowest end for subspecialists, are saying there's a shortage in our area. So even at the lowest end, a fifth of the country is saying there's a shortage of some subspecialists. And I won't go through those specifics, but you can see there's a good amount of our subspecialists here who are sitting in the crowd. Specialty. It's not very reassuring, and it looks like the general pediatricians in the community can feel it themselves, and they're getting these complaints and reports from patients. This includes long wait times, this includes long travel times, this includes not following up with subspecialists due to these barriers. I think I zoom in a little bit, yeah, if you guys can, better view. And then this is a part of that same survey. They asked what specifically are you seeing for barriers for these subspecialist referrals? And if you notice, so the light blue is like moderate barrier, the dark blue is a significant barrier. Significant barrier is something that actually prevented the patient from either following up or getting appropriate treatment. So long wait times, and if you notice too few specialists, 45%. If you add them together, it's like 60-70%. Length to travel, which we'll talk about. Insurance, which we won't get into as much, but considering most kids are on government insurance, but some kids are on private insurance, and this does cause issues with if you're not in network and stuff like that. And then always the uninsured issue, and then prior auth stuff. We won't really be talking about insurance stuff, but it's something to just keep in the back of your mind. That's another barrier that patients will kind of have issues with. And I do want to mention, just specifically for rural pediatricians, they were about 16 to 70% of this survey, and they had a way more significant response in having these barriers, especially the long drive times and length for appointment wait times. Why does it matter? I think it's pretty obvious to all of us why it matters. Delayed evaluations, diagnosis, causing worse outcomes, increasing the burden on PCPs. I'm sure general pediatricians in the crowd right now can feel it. You're having to manage kiddos for a little bit longer, or trying to do things that maybe you're not as comfortable doing or not as familiar doing. And then at the bottom line, it's an increased healthcare cost, increased system cost. I think this is the biggest thing that we can do to push legislators and actually get change, because at the end of the day, money talks, and the bottom line is always important to everyone. Another, just a couple examples. Saw a couple studies regarding like congenital heart. And these are just two studies that basically was, the first one was 552 patients, and they were just
a referral line.
Phone a friend. This is just basically both studies were kind of looking at follow-up and outcomes based off of where patients were and access to special care. So one of them was looking at the follow-up appointments after surgery and the neurodevelopment follow-up, and they found that it was only 17% return for their follow-up neurodevelopment evaluation. And then the second study looking at hypoplastic left heart syndrome, they too were also looking at outcomes, and they found that I think it was if you were 90 minutes or further, and this study was in Texas, from your cardiac center, you had a 20% increase in infant mortality for those kiddos, partly due to follow-up, but partly also just due to other barriers. I really like this website, which I'll click on it, but we'll also go through some of the graphics. This is from the actual American Board of Pediatrics, and it explores the changes in the drive times over the last 6-7 years. The data is from 2025. I'm going to comparing it to 2019. Let's see if this works. And you can like go through, I'll just really briefly show you guys. You can go through different specialties, and we'll talk about it for them, but it has all different specialties, and then it's a nice little comparison graph, kind of averages it for you, and then even more importantly, it'll show you a heat map. And so we'll come back to heat maps, but just keep in mind, this data is averaged across all of the United States. So if you'll notice, there are portions of the country that, there's very few, if any, specialists for hundreds of miles. We're over here, and we'll come back to this, but all right, let's jump into it. So Peds GI, I chose a specialty. Peds GI is actually making improvements. I feel like overall, most of these specialties are trying to make improvements on access. Slight decrease in the average driving distance, but this is over 6 years, and this is with programs and push to get access. And we've only, 2 miles is supported by 10 minutes, maybe 6 minutes, depending how fast you're driving. Peds Endo, similar, only 2 miles, change over the 6 years for the average. EMOC, barely changed. Palm, Quick Care, a little bit better. Just trying to give you a sense of, we're making progress, but minimal progress. We're making baby steps in the right direction. And then this is the same map that I showed you guys on that website with the cardiology, but there's a similar map to this for all the specialties, and the cardiology one actually looks a little bit better than some of the other ones. And then this map is also from them, but I like this one a little bit better because you can kind of zoom into the actual county. So let's pick, let's see how up to date this is. I should have checked this last night. And then let's go to Virginia. Oh, is that you? There she is. There she is. Pediatric nephrologist in Roanoke County. She's sitting right there.
We're very close driving distance.
So it's something you can play around with. I did not go through all the subspecialties, but feel free to. You'll see most of the subspecialties. The map looks almost identical to this. There's a concentration in outside like Charlottesville area. There's Richmond. There's Norfolk is here, and then there's Northern Virginia. Everywhere else is pretty much minimal. There are some clinic groups and groups that do go to like satellite clinics to kind of reach some of these rural areas, but it's kind of minimal. And so this map is very, very typical of most of the subspecialists maps on this website. All right, so let's back up to actual students entering general peds. So this is MD graduates. It's probably no surprise to you guys, but over the years, general pediatrics, both the competitiveness as well as the interest from applicants in medical schools has been going down and down. We have two medical students in the back right now, and both of them do not want to do peds. But that's one thing that we're actively working on. We're trying to encourage students to get involved and get experience and exposure to pediatrics earlier on. We're trying to do other outreach things for students to kind of plant the seed earlier on. But even with these efforts, things are dwindling down. I think it's no surprise to everyone in this room. Part of the reason is compensation and financial reasons. By part of the reason, I mean large part of the reason is that this is just a little bit more of a breakdown. If you look at peds at the bottom, the percentage of applicants is 45%, but the matrix is still pretty high. So if you're MD applying. And then I kind of went down all the different types of applicants. There's DOs, they make up 20% of peds applicants. There's IMGs, so this is United States born international medical graduates who go overseas for medical school, make up 7% of pediatric residents, and then 21% are non-US IMGs. So they're making up a good chunk after the MD portion. And then this is the fellowship. This is the fellowship unfilled programs. And we're going to kind of dive into the fellowship match in a second, but just wanted to kind of highlight there's a good amount of unfilled programs, and some of these programs actually have more than one spot open. So even my short field GI had 5. So let's dive into it. So just real quick to explain this, this is from NMRP, so National Medical Residency Match. It's comparing the last 4 years. The graph works by like the top ones, the actual programs, the middle ones, like the positions they're offering, and the bottom ones, the applicants. If you're overwhelmed by this graph, just really pay attention to the positions that went unfilled. So this red bar down here, which one's saying 0, and then pay attention to the applicants right here, the position, I didn't say, but it's number of applicants and number of applicants matched. So kind of these and this bar, I'm actually kind of go through. This is academic general peds. This is developmental and behavioral peds. I'm sure the general pediatricians know the long wait times to our own developmental clinic. If you notice, there's plenty of unfilled spots every year. It is improving, but this graph is showing the amount of applicants per spot. So there's more spots than applicants. NICU is actually one of the ones that are more competitive in the sense of numbers, but still there's 44 spots going unfilled. It's one of those ones that's also less reported as having shortages in areas, but there are still reported shortages. If you notice, see they almost have 90%. Cardiology is also one of the more popular ones. You know, it's always been kind of low. Yeah, last year was a little bit of a weird year, but only 3 unfilled positions this last year. Crit care is having swing the other direction. Looks like last year, not as many people were interested, but crit care is also one of the ones that is not as reported as a shortage. Yeah, similarly, kind of, I think COVID may have changed things for people applying to EM. Again, 27 spots unfilled. And Dr. Tillotson. And if you notice, it's going up every year. You know, for those of you who are in residency or students who are interested, you know, these specialties are not as competitive because of these open spots. If you're interested, definitely explore it. But you'll notice a lot of them are the same way. GI had a competitive year this year, very competitive year. But it looks like it ebbs and flows. Last year, the year before, not as competitive. Hemonc, similarly, a lot of unfilled spots. Hospital medicine, for those of you who don't know, the American Board of Pediatrics started a hospital medicine fellowship for 3 years. You can do inpatient general peds. It's very controversial. Oh, 2, excuse me, 2. It's very controversial amongst some residents and some attendings. I'll leave it at that. ID is one of the ones that's one of the highest reported shortages, and they have a hard time filling every year. I don't think they ever have any years I look back, but they have positive trends. Our own ID department has Dr. Fallhaber, and we rely on him so heavily. Nephro, equally as bleak. It's getting worse over the years. Sorry, guys, it's not a positive presentation. Paul had a more competitive year last year, but still 32 spots unfilled. Room, we don't even have a room in-house here. We have to call out for. This is the kind of full breakdown. I don't know if you notice, some people apply to multiple subspecialties. Not sure why it's not as competitive, but so even though it said we had increased applicants in certain specialties, it might be even lower just because they're dual applying. I really like the survey. This survey is a part of the annual survey they give out, and they did this over 3 years for 7,000 something residents. And they basically surveyed them, and one of the questions was, do you intend to pursue fellowship? And 65% said yes initially. And then over the 3 years, something happened in their experience. We did something, I don't know what happened, but the number drops to almost half. I think it's 55% of the initial ones. So at the end, we might ask some of these residents in the crowd if they had plans or intentions to pursue fellowship. And if they did, what happened? Because I'm the only fellowship. But I'll talk about the reasons that I found that were highly reported. Do you have a comment online? So a few things, obviously money. One of the biggest things is a lot of medical students take out loans. Dr. Tillotson brought up a great point that loans used to be paused, interest-wise, when you were in training during residency and fellowship. That is no longer the case since the 2010s. Saying that loans are also changing in the last year or two. They've now capped grad student loans. So going forward, students, if their tuition is over the cap, which I think is $200,000 or $250,000, if your tuition is over that, which mine was, you have to find other routes to acquire that money. So whether that's private loans or other things, and those avenues don't have as much protection and as much support in loan repayment and plans like that. So it's just something to consider that this problem actually might get worse. The other thing is length of training, which we're going to talk about in a little bit, but as of now, most, if not all, PEDS subspecialties from the Gen PEDS pathway are 3 years of training. There was a recent announcement, which we'll talk about, that they've discussed maybe making it 2 years, and they've kind of put in a plan in place, but that won't happen until 2028, so we'll talk about that. Burnout, which I'm sure a lot of residents can feel. Some of the attendings might say that going to become an attending won't help that, but I think a lot of trainees feel that they're tired of certain work schedules or certain hours, and so they want a little bit more control of their schedule. And then the last one, which may be something that we can also affect, is lack of interest. Sometimes it's due to exposure earlier on, whether that's medical school or early in your residency, or if it's just lack of interest in general for you're more interested in general peds. And I didn't touch on, but work-life balance as well. A lot of times you're getting to an age at residency where you're in a chapter of your life, you're thinking about family, you're thinking about other obligations that maybe limit you both in location, but also maybe in time for training purposes. Let's see. All right. And then I also wanted to mention that there's the problem we're having right now is the pipeline, and not a lot of students and trainees are going to fellowship, but we also have the other problem where there are a portion of subspecialists who are leaving their fields, whether that's because of flexibility of hours, whether that's location, whether that's money. We'll talk about it a little bit, but a lot of these subspecialties don't make much more than Gen Peds, and sometimes are making less. Location-wise, as a subspecialist, sometimes you are tied to bigger centers or to children's hospitals for the support and for treatment things that you might need. And then flexibility of hours, I was going to mention this just because I've seen the call schedule of our PEDS subspecialists, and it can be very brutal. So the problem is almost exacerbating the problem. So there's 9 subspecialists, so subspecialists are taking call like crazy, and that's making people want to leave the field or shy away from entering the field. So thank you, subspecialists, for taking call and having a hard schedule, because we appreciate you. But it's just something to consider that the problem is making the problem worse. Oh, perfect. Sorry, this graph is a little bit blurry on this. So this was a study that they did in 2021. I think the data is actually from 2020 and 2019. And it's basically looking and estimating the average financial returns for graduating pediatric residents. They even considered 2-year fellowships back then to see. And if you notice, there's only 3 subspecialties that you'll actually make out ahead. That's cardiology, critical care, and neonatology. This is just averages, so obviously, there might be some in these fields that make a little bit less, and some of these fields that make more. But on average, these are the only 3 that trainees can guarantee that they'll come out on top financially. Emergency medicine is kind of on the fence, and then general peds they're using as a benchmark. But even PGI, neurology, which I guess was not through peds, but you can see that.
NPV stand for?
It stands for. I just looked this up. I have it.
So is lifetime relative to Gen Peds, right?
It's,
Relative to Gen Peds?
yeah, return or something like that.
Oh, yeah, like.
Yeah.
The years of fellowship equating to.
It stands for net present value, but it just means total.
Okay.
Taking the.
Compared to if you don't do fellowship.
I'll let you guys kind of take this in, but the gist of it is money talks. If you even look at medical students applying to residencies, you can ask them questions in the back. The most competitive specialties applying to are generally the more compensated specialties. And it's something that we got to kind of work on both as a pediatric community, but also as a healthcare system nationally. This is another really good graphic. I do want to mention, this is from the same study, I believe, from 2021. And this is just looking at lifetime earning potentials between pediatric subspecialists versus their adult counterparts. And as you can see, across the board, the adults make anywhere from 1.5 more to 2 to 3 times more. And that's just across the board for every subspecialty. And that does not mean that they do more work or that they have higher hours. A lot of times this is due to procedures and the percentage of procedures they're doing versus their pediatric counterparts. Additionally, part of the issue is that most of children are on government insurance. And even if they're on their parents' insurance, for whatever reason, the reimbursement rates are typically lower for pediatric treatment. This is a study that is not technically published. It's pre-published in the AAP, but they basically looked at the lifetime earning potential from 2014 to 2024, and it's kind of similar to the previous graph, but just comparing pediatric subspecialists to adult subspecialists, and basically the change over time. So this graph kind of gets a little overwhelming with the colors, but the gist of it is the lighter color is 2024, the lighter orange and beige, I guess. And then the blue colors or 2014, excuse me, 2014, and the blue colors are 2024. And it's basically comparing the change both in the salaries and also the difference. So if you notice, most of the pediatric salaries barely change. Some of them are going down, but most of them don't change. The adults, it's kind of the opposite. They all have a little bit of a bump, but most of them are going up. What does this tell me? It tells me that either they're advocating a little bit better when they're discussing things on a government level, at the national level, maybe they're getting better insurance rates, or just it seems like they're keeping up with inflation, but we are not. And that's just across the board. And then if you notice, the gap for most of these is widening. So I think it's not been a secret for decades now that pediatric generals and subspecialists are getting paid less than their adult counterparts. And there's been a push to kind of maybe not make it even, but at least make it a little bit more comparable. But overall, it seems like we're going in the wrong trend. So a couple of things I want to mention. Part of kind of this compensation thing is there are pushes at like a government level and a legislature level to do value-based care. This is more about paying for outcomes rather than procedures. Part of the reason, for example, GI, my chosen field, part of the reason why the adult GI docs and our PGI subspecialists don't make comparable salaries is because the adult GIs are doing 3 to 4 days of scope sometimes, scoping all day, and they're just doing procedures, and they're getting more compensated than our subspecialists who are maybe doing other modalities or doing their best to prevent a scope. But money pays for the scope, so they push the scope and they get more money. So this is being pushed. The problem with this is, like I mentioned, most pediatric patients are on government insurance, and it's kind of a big pie. They take a chunk of the budget every year and, earmark it for healthcare. And so if pediatric subspecialists take more of that pie, they'll have to be taking it from other specialties, and other specialties might have better lobbying, or they might feel a certain type of way of reducing their salary or reducing their reimbursement rates as well. So it's just something to keep in mind while we talk about pay. And then this is another great article that I read in the Journal of Pediatrics. They were arguing that one of the reasons that general pediatricians don't want to go into subspecialty, both from residency but also from just when they're already out as an attending, is because they don't want to take the financial hit, whether they have family obligations or just their own financial obligations. It's tough to justify going back to a fellow or resident salary after making an attending salary. So this was a really good study that basically just said if they could, maybe increasing the fellowship salary to at least be the 25th percentile of a hospitalist, so that way you're not feeling like you're losing out on a lot of money or a lot of financial benefit. The other argument I've heard is maybe paying them the equivalent to a AAP, like a allied health providers, like whatever a nurse practitioner or a PA may make in that clinic or in the health system. You pay the fellow that much so that at least they get a little bit of a bump of salary, which I do think sounds fair, but I'm not biased. And then then there's also a bunch of loan repayment programs. I'll talk about this one specifically because it's more of a national one, but there are plenty of state ones as well. There's multiple in Virginia, and especially a lot of the rural states or a lot of states that are having issues with shortages. This is both for gen peds and subspecialties. So if you're interested in going somewhere out that needs more support and better access to care, there are programs out there for you. These programs are pretty good, but they all have like very specific requirements, and almost all of them have commitments over 2 years or 3 years. So this specific program is a federal program. I think it's 3 years, and you have to either go to like a shortage area or a medically underserved area, and they have those areas already marked. And then the only real requirements is you have to be a permanent resident or U.S. citizen, and then be fully licensed, and then just work full time for 3 years. And then it could be, this program specifically is for pediatric subspecialists or in medical subspecialties or surgical subspecialties. All right, now we can talk about fellowships. So there's been a lot of talk about this pipeline and why are students not applying and what we can do to kind of boost those applicants and boost the interest in fellowship. And it's been talked about for a while now, but it sounds like this year they finally kind of made it more formal, and they announced at the recent conference that they are going to try to do a 2-year fellowship. I do want to put the caveat out there that not all subspecialties will be on board with this. It sounds like already NICU's fellowship board people are kind of pushing back already, and maybe cardiology as well, I've heard, but I've not confirmed that. But it sounds like most fellowships will go to this model. It's not planning on even being instituted or starting to be instituted until like 2028 or after, so it might take a couple of years. There's a consideration that next year's applicants, so the second years who are listening, there's a consideration that they may not apply to fellowship next year and just wait and hold out for a year, especially considering that they might graduate at the same time. The biggest change is going to be they're dropping the research requirements for fellowship, saying that you still will have the option, from what I understand, to do a 3rd year and to do research, but now it's going to be more competency-based, meaning they're going to have certain metrics, kind of similar to how we do residency right now, but and then as long as you meet those competency milestones, you'll graduate in 2 years. It'll be kind of up to your program and program director kind of make sure you're meeting those milestones. So you might end up still being 3 years even through this model, depending on if you struggle. And then, like I mentioned, the transition won't start till 2028, and they haven't really given much details of how they're going to transition. I don't know. doesn't seem like it's gonna be like kind of like a light bulb and all of a sudden it's gonna be 2 years. It sounds like it might just be like a stepwise approach and maybe take a little bit of time, but I am very for this, but I will not be able to benefit from this. I think that most, yes,
Oh, sorry, finish your statement.
no.
So I was just gonna say, the 2028 is the ABP requirement to sit for the boards. And so no longer do you have to complete 3 years or an academic project in order to sit for the board. So that's what the move is. So they don't actually have, they don't dictate what a fellowship does in their nuances, but to sit for the boards, you only have to complete 2 years and you do not have to have an academic project. So that frees up the fellowships to then move things around. And then of course they have to meet competencies, which is coming to residencies too, more to come later in the
I
month.
know Peds Nephrology is thrilled about this. They're 100%.
Is Endo excited? Is Endo excited about this?
TBD, I'm thrilled.
TBD though.
Erica Reynolds is thrilled. She just went to Peds Endo Society. We have a lot of really old Peds endocrinologists that I think are gonna hang on to that research. Peds endocrine really like boost up their research and they kind of think of clinicians as like those people who are kind of crazy that are taking care of patients, right? So I suspect there's gonna be a lot of polarizing division, but I don't think we can deny that we're a dying subspecialty. So they're going to have to change some of them.
That's what do you think about it?
I had a fellow in my year, finished 2 years, returned to India, and is doing fine, opened his own sleep lab, and so you can thrive in the situations you make, but there's the caveat of who's going to be pushing the front of knowledge in these subspecialties. So having that encouragement, which, this sounds to me like discouragement for that kind of career path is worrisome. We're going to leave, intellectual advancement to industry, which is you can make a lot of money in research and industry too. So maybe that's a pathway, but then where is it for the subspecialists? So, but it's also true that subspecialist burnout is a big component of it, and a lot of it. We like to work within a village of our peers, and so particularly subspecialists. If we don't have that, then you're going to have more folks leave the workforce after fellowship than remain.
I do just want to point out adult fellowships are often 2 years where peds are 3. So like endocrine is this exact model. Adult endocrine is 2 years. There's a 3rd year if you want to do research. So they're still doing research and being innovative. Adults have figured out how to do it. I know there's more of them than us, but I do think there's still going to be people, depending on the field, that are interested in research that'll do research. But like I did a very research heavy fellowship. I was NIH funded for 2 years and I'm here. So like just doing the research didn't like actually put me into that field. And I think that there's people who are going to want to do both. We just have to figure out how to foster that too.
It's a great point with the adult specialists already doing 2-year fellowships. Or so
And they pay more.
Yes.
Shorter fellowship,
and
more
they
pay. Longer fellowship, less pay.
Yes.
Doesn't matter.
Anything to add?
I had heard murmurings of keeping it 2 years or 2 years, but with the opportunity in GI to, if you were much more clinical focused, then that was what your 2 years was going to kind of be mostly focused on. You might have like a little bit of research in there, but then if you were primarily interested in research, then a lot of your fellowship is going to be geared towards that. So I thought that was interesting. Again, that was just kind of like rumor. I don't know if that has any teeth to it, but I think that would be a reasonable way to do it, if especially if people are interested in research. You can kind of preserve some of that. But yeah, I think when it comes to it, a lot of it just kind of varies on where you want to practice and what you have available to you. There's a lot more opportunity, I think, in the adult world if you were really research heavy to be able to go and form a career with that. Whereas pediatrics, if you're going to go to an academic center, which is most of Peds GI, you still have to have clinical competency. You have to have procedural competency. So, I don't know, you get into the weeds pretty quickly and it's controversial.
Yeah, for sure. Be interesting to see how it shakes out. Yeah,
Yeah, and just like to the point that Dr. Tamez was making, when you think about the number of people who are IMGs that go into residency in PEDS, there is a number of people that actually match into fellowship that are IMGs. If you don't do residency in the US, you have to go back to your home country. So you can do fellowship for 2 years, train here, then that's a matched position that will maybe confirm those tables that you were showing, but then you have to go back. So there's really not those specialists that will stay in the country. They're just gonna go back. So that is also interesting.
Okay, interesting. Yeah, that's a good point because there are a good chunk of subspecialists or trainees who are foreign grads who maybe have to return to the country. So it's another reason that they might be leaving. All great points. It'll be interesting to see how this kind of shakes out over the next few years. It'll be kind of controversial. Speaking of controversy, this was published right before they announced. This analyzed what they call clinical entrustable professional activity level supervision, and they followed fellows over 3 years, and they just to see if they met the minimum threshold of competency before graduation, minimally in the first year, and most in the second year did not. And this article is basically arguing against reducing it to 2 years, saying that this is with the current model. So, this is how they're trained them currently with the research focus and not pushing the competencies and clinical focus. So I realized that they had very strong opinions in this, but I think this is with the current model, the way we're doing things now, they probably wouldn't be ready, which I wouldn't expect them to be ready because the way it's designed now is to get them ready in 3 years. At least that's my take. The writers of this article felt very strongly that going to 2 years might become a disaster. Like, did you guys look at
So, that sounds like asking a high school junior to take a senior test and they're not ready to take it. Also wanted to know more about the metrics of exactly the competency and how much of it was sort of self-professed feeling of readiness.
A lot of it was.
And if we currently, asked third year general PEDS residents, do you feel ready to be an attending, whether the numbers would be
Fair points.
And Dr. Turner, who is the penultimate author, he was the one who delivered the news to the APPD and sits on the executive committee of the ABP. So this is published by people who made the decision to go to 2 years still.
And we were just talking, my first 2 years were all research, my third year was clinical, 1 year clinical.
You didn't feel clinically ready after 2 years?
I was not ready to practice clinical peds endocrine at the end of my 2 years of sitting behind a computer doing research. And I do think that different programs are set up differently. Some do your clinical in your first year, and then 2 years of research, it's all different. But
that's a fair point. You would not.
I wouldn't be ready.
I was gonna say, I was with one of our visiting subspecialists who's one of a program director for their fellowship, and he said theirs is actually sprinkled in somewhere like residency, like they have blocks of research. So do throughout each year, and so he was saying that for him, he thinks it'll affect fellowship burnout and lifestyle in those programs where it's typically sprinkled in, so those are easier months or easier blocks if they're cramming everything into 2 years. So.
But they would be removing the research part too, so it would be less work overall in the 3 or in
Yeah,
2
he was
years.
more just saying from the work-life balance.
Yeah.
That you do, he's you can work from home, you can work on your computer, you can do things depending on the specialties.
Yeah. But also based on research, your interest, But I think that's kind of I'm sorry, we're hijacking your time. I think that's kind of the beauty of allowing somebody to be eligible after 2 years is if I had been applying to PEDS endocrine now, I probably would have picked a 2-year program like UVA, because I imagine they might go to 2 years, or Rutgers, places that focus on clinical, as opposed to Columbia, that is never going to go to 2 years. They get all their funding for research. So I think that's the beauty of allowing it to be 2 years. You let people pick what they want to do, and then it's like a track in residency where you focus in on that.
Well, I didn't realize some fellowships are paid for by the NIH. My fellowship was paid for by Vanderbilt, so they would have been glad for me to finish master. I mean, we weren't getting
just 2 of my 3 years.
We weren't getting outside funding, so that's got to be a huge driver too.
Right. I'm sure the NIH funded ones aren't going to go to 3 years because a T32 through the NIH, which is what funds the fellowship trainees, those are 2 years in length. So you have to do research for 2 years.
That's interesting.
So you're not going to do a 2-year fellowship because you have to still have a clinical year
Right.
to be competent.
To your point, it's like if the applicant or the trainee wants to do that, then it's perfectly, there. It's perfect for them. And if they don't want to do that, they should have the option to not. But it's my opinion. I feel like it's the option. Oh, that was you, Dr. Okay. I like this discussion. I'm almost through my slides. I talked fast. This is a really cool graphic that I got from one of the previous articles I talked about, the Raising the Bar article from the Journal of Pediatrics. This is kind of showing, they try to kind of diagram out like a nice little flow thing of what kind of causes less applicants and less interest in pediatric subspecialties. It's kind of hard to figure out where to start, but I started here and just kind of went through. But low reimbursement, we talked about that. Compensation benchmarks kind of contributing to that. When our subspecialists and our general pediatric attendings are burnt out, they're not as inspiring as role models. They're not as active in the training of trainees. Me personally, part of the large part I am applying to GI fellowship was because of the attendings I worked with in clinic. Not to suck up, but I didn't have much. I had much exposure to PGI before second year. I applied really late, but part of the reason was I worked with the PGI attendings, and they kind of planted the seed early on in the fall. When I went back in the spring, I was like, yeah, I really like this. And I don't think I would have had the confidence or even the want to go into the field if I didn't work with them. So I'm thankful to have worked with them, but it's one of those things that you're burned out if you're having a lot of call, which you should see some of our subspecialist call schedules. I feel bad as a resident even complaining about my schedule sometimes. But this all contributes to the burnout. It all contributes to them not having, the energy or even the time sometimes to educate residents or to work with residents. There's a good example here, especially in small departments. And then comes back to the access of care. The thing is always comes back to access of care. So the main point of this entire talk, yes, I want more people applying to fellowships and getting more trainees, but the biggest thing is access to care. We talked briefly about the congenital heart, but there's plenty of complex and complicated kiddos out there and diseases that general pediatricians are having to manage, or that these families are having to drive, hours and hours away, or even get hotels or, long stays just to get care for their kiddos. And it's not sustainable for some of these families. Some of these families are, on the brink. And then some families just decide not to do it, and they just kind of, let kiddos suffer. So it's a little bit tough, and kind of hits close to home for some of us. I'm sure all of us have taken care of kids who are in this situation. It's tough to kind of get some of these barriers, both socially, but also distance and access-wise. And then I was going to leave the floor up to other ideas. So we talked about there's loan repayment. There's we're doing stuff with the medical school to get medical students interested. We're trying to reduce the fellowship length, maybe increase fellowship pay. But what other ideas do you guys have? Yeah, Dr. Drake, what other things are on your guys' mind? I don't know.
Yeah, so the military is an interesting paradigm for this, because when you are licensed in the military, you're licensed across all state lines. Now, you can't provide care to non-military people, but because of the way the statutes are, I would actually, in my previous job, we would have one of the most common referrals to peds cardiology is a murmur in a baby, right? And so we want to sort this out. So they trained us to do echoes. And so I did tele-echoes with cardiologists in Washington State, and they find, it's a VSD, it's no concern, but we also identified a truncus, and we also identified a transposition. And we're able to appropriately triage those kids from the nursery to go straight versus having to transfer them, and separate them from their child if it was, something less concerning. And so there's the workforce side, but then there's also the payer side where, we are individually state licensed, and that creates fragmentation of care as well, and an inability to bridge gaps. And part of that too is liability. Right, and so what kind of liability are they incurring by having somebody else do an echo, and do I have something lost? And so there's even the malpractice side that needs to be protected, right? If we're going to actually break down these barriers, and to make pediatricians feel more comfortable managing these things, right? When you're 3 hours away from a GI doc, I'm really sure this is constipation, but this is just the worst constipation I've seen in a while. and, to help them feel more comfortable managing those things. Like, there's other ways to help increase comfort that it requires protecting and breaking down kind of access barriers and then protecting the people who are trying to be the boots on the ground closest to the patient.
So there was a recent article in JAMA asking who is going into pediatrics as a specialty. And so women, no surprise, people who wanted to do clinical medicine versus research, they tend not to go into pediatrics, and early exposure. So we all know early exposure, but that article highlighted pre-med school early exposure. So there's a lot of talk and discussion in how early do we need to start that exposure. And there are some programs. So as a department, we participate in college students immersion program every year from lots of different colleges in Virginia. There are high school students that sometimes ask for shadowing opportunities, but it's very limited on what we have to offer as a department. And then at the med school level, we are trying, and we have tried in the last few years to either have pediatricians in front of students or creating programs so the entire med school first year class came to our department as a clinical immersion last month, this is the second year, and we are in the process of creating a little early immersion, early exposure program with the subspecialists specifically, where kind of casual, like quarterly, they'll meet and greet. And we're hoping that from that, maybe it'll be not just a meet and greet, but maybe it'll foster mentorship or shadowing opportunities. So there's a lot of discussions, and I'm open to anybody who has any other suggestions, but trying to promote early exposure. Because genuinely, the number one comment that I hear after their rotations is, I didn't know that's what pediatrics was. I didn't know that you could do this in pediatrics, or these were the options. So as a specialty, we are so under, what is the word? We're like a sleeper. Yeah. We're sleepers.
We're like top secret. People don't know what we do.
We are top secret. We need to share our secrets a little more. But.
Before we go, do you know how many students in this graduating class applied to pediatrics or math pediatrics? Just one? Okay.
One categorical and one med peds. What we lack in quantity, we make up for in quality.
I think as much as undergrad students and med students, you made a good point, Nima, like how much do we need to be pushing our residents for early exposure? Like I haven't been to pulmonology this week for the first time, and I'm almost finishing out my second year. So what if I do go to Palm next year? I don't even have it this year. And I'm like, oh shoot, I love this, but now I'm already missed the cycle to apply for fellowship, and there's other things. So I think that's also something that maybe early exposure and intern year, even if it's, you have a week where it's like your early exposure and you go to a half day each clinic or something as an intern. I know our time's limited, but, the only side of things I'm seeing from the subspecialists are when I'm consulting them for very specific things from the hospital typically. So I think that I definitely agree. The early exposure is good, but also for the residents that are in a program, that could make a big difference too. Because like you said, you probably would have known even earlier that GI was something you were interested in.
Yeah. That's great.
I have a question.
So as a non-US IMG,
Yes.
okay, is there immense hurdles if you do a fellowship and you still want to stay in the US? It's hard, okay? And you have to do, because you're on this kind of a visa that you have to have, either go back to your country for 2 years or stay here and do general peds. Okay, for 3 years in an underserved area. And then after that, it could take 3 years. In my case, it took 7 years. Okay, it took 7 years before I could leave that area. And it was because of 9/11. Everything slowed down, it just, and so after 7 years, you've been out of it for 7 years to try to get back into it. It's not, it's not possible. And so a lot of the IMGs if it would be easier for them to, to stay and practice their fellowship.
We'd have to
But that's
allow
not, but that's
what
not,
happened with
but that's
3
not,
years of.
now, there are certain states that allow non-US IMGs who've done their residency somewhere else to practice. They get a limited license and they can practice. It's a few states.
Unlimitedly, like you just practice?
They can practice, general. But so there are some states that are trying to do that, but it's not, apparently Texas is one of them. But yeah, it's hard and, so.
I want to give a shout out to neurology, actually, which Dr. Rana is leaving, sadly, but she has been really helpful in connecting students with doing case reports and getting publications. And that was from very minimum exposure. But I think part of it is we can create programs, but it also takes initiative on everyone's part, because literally one of these students came for 4 hours for an exposure but followed up. And then they got to talking, and I have a great case, would you like to write it up? And then it became something else, but that's not typical. But I think, there's initiative on both sides that are needed, and maybe our role is to foster those, at least putting them together and putting ideas into people's head of what is possible, and hoping that it takes off on its own.
I was just going to say, based on kind of your earlier point, Dr. Parmeshwar, the exposure for medical students and talking about early exposure, but I think also what I've heard throughout my time talking with residents who are in other specialties who decided not to do pediatrics for some reason, say they decided family medicine, and a lot of it had to do with the type of exposure they had in medical school to pediatrics. And I find it interesting that even though if they have a clerkship, there doesn't seem to be any standardization that I can tell amongst medical schools as to what that pediatric clerkship looks like. And so some people come into residency having never done inpatient pediatrics at all. And I'm just thinking, that's interesting. That's going to be most of your residency is going to be inpatient, and you have no clue. And I think for some people who really like that inpatient medicine piece, if you are not exposed to that as a medical student, then you're not interested in going into pediatrics. I had a family medicine resident as a neighbor for a little while. He was like, I might have considered peds if my whole clerkship wasn't just seeing ADHD patients. And he was like, I just felt like that's all I saw. No, he was family medicine. He did not do medical school here. But he was just like, that's all I saw. And so I just thought, pediatrics, I'm just going to see a lot of ADHD, and I don't want to do it.
I just came back a month ago from our pediatric clerkship international meeting. And this is the topic all day, of course, every day. And the first time I went, I was shocked at the lack of consistency. So it could be 4 weeks, it could be 12 weeks. And it could be entirely inpatient, it could be entirely outpatient. And there's no standardization. The way we evaluate is completely different all over the country. So, at our institution, we try to give them a balance of inpatient, outpatient, which is not typical. There was a lot of posters on how do we foster this. So in some schools, you can have electives as a first-year student, and a lot of them were creating electives for pediatric subspecialty shadowing. We don't have that. We don't have that as a first-year student. So some schools have that, but it's shocking the lack of consistency there is across the board. One of the other things they pointed at is, as medical schools around the country, who is teaching not only is there not a lot of pediatrics in the curriculum, it is not always pediatricians teaching the curriculum. Like there are some studies interesting, and they mapped it, and less than 3% of the content was being delivered by actual pediatricians in some places. So not only, and you guys can speak to your curriculum, like how peds heavy was it in med school?
It feels like we're introduced like sort of the content of like congenital anomalies, embryology mostly, but it's kind of interspersed. It's not really grouped together. So it's hard to, I have found it, I mean, Dr. Tillotson saw me week 1 and Dr. Permashore has seen me now. I have learned so much, so much from.
That's your first exposure to pediatrics.
And like, it was hard to like kind of shape what pediatrics was content-wise, even in preclinical. And now I'm grateful for what I've learned, but it definitely could have been introduced earlier in a better way. I do think, to your point, a lot of the lecturers were non-pediatricians teaching sort of, like this is indirect hernia. And
I know in PBL, having done some PBL, physical exams on infants, they basically took a geriatric exam and like sized it to, like, an edonculous baby reporting for such, and I was like, all babies are edonculous. I don't use that term.
Never have I ever.
There really were not very many pediatric educators in the med school, so we really have a good opportunity there, I think, to reach out and.
what about like like at least one case being like pediatric? Now we go through like 2 cases now per week. I feel like it's always like 2 adults with 2 different adult.
Yeah. Yes, this is my constant. Why can't it be a pediatric patient teaching about anatomy here or cardiology here? Who knows cardiology better? Who knows anatomy better than a cardiologist? Like you have to think about it in that way. Like, how do you get exposure?
Yeah.
But it's an ongoing challenge.
I just wanted to throw one more thing out from what you were saying in the very beginning. Not sure the map will ever be evenly dotted. Certainly, there's some land masses that don't have people, as we know when we look at election maps. And I think it is good for subspecialists to be at a hub, right? Just like we don't necessarily want every podunk hospital doing transplants. But one of the fundamental difference that comes down to payment plan is that Medicaid is not really insurance. It is a government payment plan and safety net that provides some really wonderful things that private insurance does not. But it is fundamentally not private insurance. The people who participated have very limited choices. And I think to say it is government insurance is blurring a line. And also to even point out that Medicaid is not funded the way Medicare is. And that puts us in distinct silos away from our adult providers.
Yeah, for sure.
Can I do a call to action real quick?
Yeah, please.
I love like ending on a call to action. So Peds Endocrine has this thing called Peds Endo Discovery Program because we realized like we have so many old people in Peds Endocrine across the nation, like we're decreasing.
Yeah.
Mature people, no, like people in their 70s who should normally be retired, but they're staying in practice and they want to retire. Peds Endo Discovery Program funds any year medical student or first or second year residents. PES national meeting, they have like a separate thing where they foster relationships with fellows. They've done this, and attendings, they've done this for the last like 5 years. They had 90 people go this year, which is more applicants than we have in the match normally. So Peds Endocrine's been really trying to do this, and I would encourage my fellow Peds subspecialists to try to see if there's professional societies can do this as well. I think we're the one of the specialties that is the canary in the coal mine, so to speak, but I think it's coming for other ones too. So that's my call to action. Try to get them And it funds a trip. So I try to phrase it as like, if you're interested in pizza and endocrine, fine. However, free trip to wherever, like where the conference is, and maybe you can get med students that way. Nobody ever said we had to come by it, honestly.
They might just discover their interest.
Exactly. That's the whole point.
Nima, thank you. Thank you.